Good morning. Now we will be discussing the Chyluria part 2. In part 1, we have discussed about definition, etiology, symptoms, grading and investigations, including all the radio imaging. In this part 2, we will be taking the treatment part. Again, to refresh the knowledge, we will go by case scenario. 40-year-old thin-built female from Gonda presents with history of white-colored urine for 2 years. She had 2 episodes of retention of urine with passage of white clots. On examination, patient is anemic, having bilateral pedal edema, and her examination of the abdomen is within normal limits. We have discussed about the provisional diagnosis. We have discussed about the correlation of clinical symptom. In the management part, we have discussed about the investigations. Now we will discuss about treatment. Treatment, you need to understand that we need to treat the cause, whatever is the etiology, whether it is a filarial or non-filarial, tubercular or tumor. Then we have to treat Chyluria itself, that white color of the urine. And then of course we need to give supportive care along with follow-up. As I told previously, whatever I am talking, it is the stuff taken from these resource material, that is Bailey and Love, Campbell Walsh, the issues of the Indian Journal of Urology and our online platform clinical.com. Now the treatment part, if you see, the 50% of the Chyluria patient, they have spontaneous remission. You need to treat only 50%. And these 50% you treat conservatively, that means with diet control and the pharmacotherapy, then the endoscopic sclerotherapy, we call it EST, and then surgery. We will take up one by one. What do we understand by conservative treatment? Conservative treatment, first thing is we need to have dietary modification. We need to have a diet which should not be very rich in fat. Then we have certain drugs which are effective against the filariasis or against the tuberculosis. Then we need to correct anemia and give supportive treatment. What are those dietary modifications? First and foremost is you need to avoid the fats which are having large chain fatty acid, because you have seen, you remember the diagram, the intestinal trunk was opening into cisterna chyli. That means the fat in the form of chylomicron is absorbed from the intestine, goes into the lymph tract. So all the large chain fatty acid, they are being absorbed through intestine. But the small chain, that means the fatty acids which has got less than 12 carbon atoms, they directly go to portal vein and directly go to liver. That means they are not going to lymphatic system or the circulatory system. So we will not be having Chyluria. And the coconut oil is having carbon atom chain less than 12, and that we should use. Apart from that, we should have good cooking and food habits. What is meant by good cooking habits? While cooking, we should use least amount of oil. Either we are going to have boiled vegetable or boiled stuff or the baked one. If at all we are using oil, then we need to use the non-stick pan, non-stick cookware, so that minimum amount of oil is required for frying. We should avoid deep frying. And in the diet, if I say in Hindi, the puri, khasta, kachori, gulab jamun, samosa, all these things are to be avoided because they contain lot of food. Even the fish fry, finger fry, they are deep fried. They should be avoided by the chyluric patient. All these things are important. Then the DEC fortified, that is diethyl carbamazine. Similarly, the iodine fortified salts, they are available to reduce goiter. Similarly, the DEC fortified salt, they are available to reduce the incidence of filariasis, and if they are available, these patients use that salt only. Then the pharmacotherapy, the drugs, once we have established that what is the cause, once it is the file area, we need to use DEC, that is diethyl carbamazine, ivermectin and albendazole. These are the three drugs which are effective in filariasis. The DEC, that is the diethyl carbamazine, is used 6 mg per kg in divided doses up to 3 weeks. You have to divide the total dose into 3 parts, and in the tedious form you need to take it orally. But one word of caution is that with DEC, the worm, this is vermicidal. When worm die, they release toxins and there could be allergic reaction. So patient should be counseled about the allergic reaction also. If there are severe allergic reaction, the drug has to be stopped. For the minor allergic reaction, the dose of the drug can be reduced up to 3 mg per kg body weight. Then the ivermectin is a very good drug. Ivermectin drug is basically, it kills microfilary and it is used in single dose 400 microgram per kg as a single dose. Then albendazole, again it is an anti-helminthic drug. It is very effective in the filariasis. As a single dose 400 mg for the adult, it is to be used, and it can be used in combination also, because it is more effective if this drug is used in combination with ivermectin. Then before I tell about the doxycycline in filariasis, you should understand one very important thing. The reproduction of filarial worm depends upon a symbiotic bacteria, that is the Wolbachia species. These Wolbachia species, they thrive for nutrition upon the filarial worm, and filarial worm has got the productivity because of this Wolbachia species bacteria. So you need to give antibacterial also, and that is why doxycycline is combined 100 mg twice a day for 6 to 8 weeks. It is given so that it reduces the reproductive power and it kills that Wolbachia species bacteria. And that is very important for all of you to understand that while treating filariasis, you should always combine doxycycline as well. As I told you, the combination therapy with DEC, albendazole, ivermectin with doxycycline, all these work together, they give very good results. If suppose the etiology is tuberculosis, you need to give anti-tubercular treatment as per the WHO protocol. The conservative treatment does not include only dietary control or pharmacotherapy, but it also includes the correction of anemia, because with the chyle, the blood is being lost, and as you have seen, our patient was anemic. So you have to give some hematinics also. You have to build the nutritional level. Patient was having bilateral pedal edema. That means you need to give high protein diet so that the albumin part can be taken care of. So all these treatment together, they are going to relieve the patient. Then suppose some person is passing clots. Then these clots are to be washed through cystoscopy. You will pass in a cystoscope, you will evacuate all the clots. You can even put a 3-way catheter to constantly irrigate. Suppose there is a heavy chyluria, then you need to, and there is a frequent retention of the urine, as in our case, the lady has 2 episodes of the retention urine. Suppose this was more frequent, then sometimes you need 3-way urinary catheter to irrigate the urinary bladder. Then, if patient is not managed on conservative treatment, he or she is put on endoscopic sclerotherapy, what we call as EST. So many chemicals, so many drugs are being used. Out of them, the silver nitrate and povidone iodine are most commonly used chemicals. The silver nitrate we are using from ranging concentration from 0.1% to 1%, and povidone iodine 0.2%. What should be the protocol? The protocol differs from one setup to another setup. But yes, what textbook recommend? It is that this either you are using silver nitrate or you are using povidone iodine. You have to use only one drug. You cannot mix both. Either it can be given 8 hourly for 3 days. You have put in a ureteric catheter, it remains there for 3 days, patient is admitted. Or 12 hourly into 3 days. Or few urologists, they instill weekly for 6 to 8 weeks. Whatever protocol you are following, you need to repeat this protocol after the gap of 6 weeks. And only 2 such courses are to be given to see the effect. In this chart, I have explained that how this sclerosing agent works. If you see on the top, as soon as you have instilled the sclerosant, it reaches to the lymphatics through the fistulae, because why chyle is coming into the urine? Through the fistulous tract. Now, once you have instilled this sclerosing agent, this agent will go through to the lymphatics through the fistulous connection. So, as soon as it goes there, it causes chemical lymphangitis. Chemical lymphangitis causes edema of the mucosa, and the mucosal edema blocks the channel, and there is immediate relief. In the morning you have instilled, in the evening you will see the urine is clear. In due course of time, there is healing by fibrosis, and when fibrosis occurs, it gives permanent relief. So that means in one setting or in one sitting you have done. That is why it is said that you have to repeat after 6 weeks, so that whatever leftover channels are there, they will also be fibrosed and will be taken care of. You need to understand the basic procedure. You do cystoscopy. I am talking about the adult. You do cystoscopy, and with the 6 French ureteric catheter, you pass this ureteric catheter on the affected side. You have located whether it is right or left or bilateral. Then you estimate the pelvic size. How do you estimate pelvic size? First of all, you need to understand then this EST procedure has to be done in awake patient. You do not give any anesthesia, either G or the spinal. This is absolutely done in the awake patient. So you will instill, mind the word instill, it is not pushed. Instill the sterile distilled water with the quantity so much so that it leads to mild flank pain. That is the amount you need to measure. And this much amount is instilled as sclerosing agent. So that is how you measure how much sclerosing agent is supposed to be instilled. You need to remember certain points when you are putting your patient on EST. Number 1 is you need to give fatty meal one evening before you have called. Suppose why you need to give fatty meal? Because once you will give the fatty meal, then the lymphatic vessels which are fistulous, they will be dilated, they will be widened, and then the passage of the silver nitrate or the povidone iodine will be easier in those fistulous tract. Suppose the person is having bilateral chyluria. Chyle is coming through both the kidneys. Then please do not instill this sclerosing agent in both the kidneys simultaneously. In one sitting, you have to instill only in one kidney. You will call after 6 weeks for the next kidney. So that is how you have to do. You have to be very careful. Then, if you have used silver nitrate solution, patient has to be put on diuresis so that the remaining silver nitrate solution should be flushed away from the kidney, and that is attained through IV diuresis. One word of caution: you should never use normal saline for irrigation purpose after instillation of silver nitrate. Why? Because AgNO3 plus NaCl leads to silver chloride, AgCl, and this silver chloride precipitates. So therefore normal saline is not to be used. Before the procedure, you have to counsel to the patient that yes, look here, this procedure will cause you flank pain, you may be having certain nausea, certain vomiting, or after the procedure some blood may come into the urine. All these procedures, all these symptoms, you need to counsel to the patient so that they should not have problem. And then, as I told you before also, only 2 courses are supposed to be done. The word about povidone iodine. What we are using, 0.2%, it has got the same reaction, same mode of action It is basically a water-soluble non-ionic surfactant polymer. It releases iodine slowly and it is least harmful for the kidney and having almost the same advantage as we are having with silver nitrate. So in that way, the povidone iodine is preferred to decrease the detrimental effect of silver nitrate over kidney. You have given conservative treatment, patient has been relieved, no problems, you will follow the patient up. If patient is not relieved, you will go for endoscopic sclerotherapy. Patient is relieved, you will follow the patient up. If patient is not relieved even after 2 courses of endoscopic sclerotherapy, then you have to perform the surgical treatment. And the surgical treatment, these are the procedures like the pylolymphatic disconnection, which you can be achieved by open surgery or through laparoscopic procedure, or then it can be combined with the omental wrapping. And even if it is not corrected, then you need to resort for microsurgery, where you use operating microscope to do the anastomosis. That is used for intractable chyluria. The components of pylolymphatic disconnection surgery are nephrolymphlysis, skeletonization of the renal vessels, and ureterolymphlysis. What does it mean? Nephrolymphlysis means that you remove all the dilated lymphatic channels which are in vicinity of renal pelvis or the hilum. They are dissected and they are ligated. Then skeletonization of the renal vessel means that for 1 to 2 centimeter, the renal vessels, they are also skeletonized. All the lymphatics, they are ligated. Upper ureter again is dissected and it has to be looked that there should be no lymphatics, and even when if you find any lymphatics, it has to be ligated and disconnected. So this is 3 components, they constitute pylolymphatic disconnection. This, whether you are achieving through open surgery or laparoscopic surgery, that depends upon the expertise and the resources available in the hospital. Some surgeons do omental wrapping after doing pylolymphatic disconnection, and this omental wrapping is done so that it covers the renal vessels as well as it covers the upper ureter. And they claim that omental wrapping helps in formation of chylocele or collection of chyle after surgery, and even they do not put any drain. So again, this omental wrapping is not the only answer. It has to be combined with pylolymphatic disconnection. As I told you, even if you have done these 2 procedures and this chyluria is not treated, then you have to resort to microsurgery using operating microscope. In the males, you have got the spermatic cord. In the spermatic cord, you will just open through the inguinal incision. You will open the spermatic veins as well as the lymphatics, and you will do the anastomosis between lymphatics and spermatic vein. In females, what is the option left? There we do not have a spermatic cord, so there we can do the nodovenous anastomosis. That means we will cut the inguinal lymph node and we will anastomose the lymph node with a spermatic vein. So that is how this microsurgery for intractable chyluria is performed, and it is the last resort if at all it is not being treated. Usually it takes 6 months for chyluria to disappear after microsurgery. It is not as we have seen in the EST, it was immediate. It is not. So again you have to counsel the patient while patient is being treated by microsurgery. Follow this chart carefully. This is a summary, whatever I have told you as far as the treatment is concerned. Initially, as soon as patient comes to you, you need to confirm by urine test that it is a chyle. Once it is confirmed, then you need to localize the step 2, localize the site and site by so many procedures as we have explained previously in the part 1. Then you need to find the etiology, that is a step 3, by doing so many investigation, filarial and non-filarial tubercular tumor. then whatever is the primary cause of the etiology, that cause has to be treated. Whether it is a filaria, whether it is a tuberculosis, whether it is tumor, it has to be treated. And then simultaneously you will treat chyluria also. How you will treat chyluria? This chyluria can be occasional or mild, or this chyluria can be frequent or heavy. The occasional or mild chyluria, we are going for conservative approach as we have discussed. We can have either remission, then we will follow the patient up on the conservative approach, that is the diet control and the pharmacotherapy and supportive treatment. And if there is relapse, then we will go for endoscopic sclerotherapy, as you can see through arrow. And if at the outset the chyluria is frequent and heavy, then we will straight away go for endoscopic sclerotherapy. Once we have done that, EST, then again we will be having either remission or relapse. If there is a remission, we will follow the patient up. If there is a relapse, we have to resort for surgical procedures. And this surgical procedure, the first procedure of choice will be pylolymphatic disconnection, what we have discussed just now, either open or laparoscopic. Again, there will be either remission or relapse. If remission, you need to follow the patient up. If there is relapse, you have to resort for microvascular surgery. This is the last resort. And even if after doing microvascular surgery, the patient is not relieved of this chyluria, then you have got only one option, that is you have to keep the patient on endoscopic sclerotherapy and general measures. So that is how you manage the patients of chyluria. If you have got any questions in mind, whether it is in the part 1 or whether in the part 2, you please drop your question in chat box and then I will definitely answer it to your satisfaction. Please circulate it amongst your colleagues of different medical colleges so that they can be benefited. And again, we will meet you on some other good topic next time. Thank you.